Vicky ma'am, we can start now.
How much of audience is there? Can see 18 people, na?
Yes, ma'am.
Are my slides visible?
Yes, ma'am.
Okay. I'm not able to make it slideshow. Is it visible now?
Yes, ma'am.
Okay, so I'll start now. So we will be talking about decoding recurrent pregnancy loss, evidence-based management. We are all dealing with patients who are coming with repeated pregnancy loss. There is so much of confusion and controversies regarding what is actually considered, whether chemical pregnancy, whether ectopic pregnancy, whether threatened abortion, and all these things, or molar pregnancy, are they included in the recurrent pregnancy loss? So let us see what the evidence say. We have the latest ESHRE guidelines. ASRM guidelines are given much previously, about 2013 or 14. So most of my slides will be based on the latest ESHRE guidelines 2023. So a miscarriage is defined as a pregnancy which results in the death or expulsion of an embryo or fetus before 20 weeks of gestation, or if the fetus is less than 500 grams. This is defined by the WHO, and nearly 10 to 15% of pregnancies overall result in spontaneous miscarriages. However, only 0.5 to 2% result in recurrent miscarriage. So what is recurrent pregnancy loss? So according to RCOG 2011, RPL is traditionally defined as 3 or more consecutive, okay, miscarriages occurring before the period of viability, which is taken by them as 24 weeks. The ASRM guidelines given in 2013 say that if there are 2 or more clinical miscarriages, they may not be consecutive, but you have to confirm them by at least UPT positive or ultrasound or histopath of the POCs. So ultrasound is important after the UPT comes positive, and then histopath of POCs, any one of these two. Even if they are not consecutive, then it is taken as RPL. And the ESHRE guidelines, which were recommended in 2013, that loss of 2 or more clinically recognizable pregnancies from conception till 24 weeks, again, just the same as the previous, I'll just take this pointer, just the same as the RCOG guidelines. They also say till 24 weeks, but this is saying that even beta HCG positive in the serum or UPT positive is also considered, that is chemical pregnancy is also considered as RPL here. However, ectopic or molar pregnancies are not included. And recurrent miscarriage is another term. And this means that it was an intrauterine pregnancy. That is, you have confirmed on ultrasound and it is intrauterine. So coming to the etiology, as you can see, maximum number, we are not able to find any cause. Nearly 40 to 50% are due to unexplained RPL, including non-APLA and thrombophilias. The next big chunk is the endocrine causes, which is 17 to 20%, followed by anatomic, which is 10 to 15%, autoimmune is 20%, and 2 to 5% only are due to genetic factors. So coming to the anatomic factors, the uterine factors, it could be acquired or congenital. You know, the congenital could be any of those different classifications given in ASRM, and acquired could be cervical incompetence, a polyp, a submucous fibroid, or adhesions. These are the 4 major ones which are included in acquired. So congenital uterine anomalies are seen in 6 to 7% patients who are presenting with RPL. However, in other women who are attending gynae OPD, only 2%. So it is significantly higher in patients with RPL. So how does a congenital anomaly cause RPL? It is probably because of the reduced intrauterine volume and poor vascular supply. Coming to the cervical incompetence, a woman who has a history of second trimester pregnancy loss with suspected cervical weakness should be offered serial ultrasound. Starting from NT-NB scan, we need to do her cervical length, the width of the cervix, and we can assess it frequently every 2 to 3 weekly. And accordingly, if it is getting shortened below the threshold of 2.5 centimeters, then we can think of a cerclage. However, based on the inconclusive evidence or benefit and the possible harm which could be there in surgery, the DGD says that you should be cautious in doing cervical encerclage. So this was a very big trial, the EPIC trial it is known as, which is evaluating progestogens for preventing preterm birth, international collaborative. This was a meta-analysis and it included 31 trials and more than 11,000 patients. What they found was that vaginal progesterone and 17-hydroxyprogesterone caproate both reduced preterm deliveries in high-risk pregnancies with history of previous spontaneous preterm birth and sonographic short cervix. So not exactly abortions they are talking about. They are also including till 34 weeks. And they have said that evidence for oral progestogens is insufficient. So coming to the SRA guidelines again, trying to move this. Can you see the headings? SRA guidelines दिख रहा है?
Yes. Yes, ma'am.
Okay. So all women with RPL, they say that they should undergo at least a level 2 ultrasound, 2D ultrasound. If there is any problem with suspicious finding which is seen, then a 3D ultrasound is much better than MRI because it has a very good sensitivity and specificity and it is much cheaper. However, they say that out of sonosalpingography and hysterosalpingography, sonosalpingography is much better because it is able to delineate any polyp or any fibroid or any adhesions or congenital anomalies as compared to the HSG because it is going to inflate the cavity and we will be able to see it very nicely. And they say if there is any confusion or 3D ultrasound is not available, then MRI could be done. So for all patients of RPL, it is recommended that you do a sonographic assessment. And ideally, if there's any suspicion, then 3D is much better than MRI based on the cost effectiveness, cost benefit ratio. So this was the only one RCT. You all know that RCT is the level 1 evidence. So there is only one study which was done to see septum resection versus expected management in women with septate uterus. This was an international multicentric open labeled randomized controlled trial. And what they found was one group was in one group they did septal resection. In the other group, they did not do anything and they just left her for expectant management. And look here, in septal resection, the live birth occurred in 31% patients only, whereas in expectant, it was 35%. So there was not much difference. However, there was one perforation also which occurred during septal resection. So based on this small RCT, the HRA guidelines say that there is no benefit of using hysteroscopic septal resection. And they say that metroplasty should not be done for biconjugate uterus, uniconjugate uterus, didelphys uterus, and there is insufficient evidence supporting hysteroscopic removal of submucous fibroids or endometrial polyps in women with RPL. So what they are recommending, I think the clinical practice that we are following, at least I am following, and most of the people, I'm sure you must have also seen that if there is a submucous fibroid or polyp then we are generally doing surgery for that, because most of the time these patients are also going to present with severe pain and abdomen and also heavy menstrual bleeding. So it is said that the surgical removal of intramural fibroids is not recommended, which is okay. Most of us are not doing until the endometrial cavity is being pushed or it is jutting inside the FIGO the grade 3 or grade 2 we are doing. There is insufficient evidence of benefit of surgical removal of intrauterine adhesions for pregnancy outcome. This is what is ESHRE is saying. Now coming to ASRM. So what they say is that some limited studies indicate that the hysteroscopic septum resection is associated with a reduction in subsequent miscarriages. Sorry. And improvement in live birth rates in patients with history of RPL. So unless she's coming with history of RPL, she is a normal patient, you just find out that there is a septum, there is no need to subject her to surgery. If she's coming with infertility, less chances that this is the culprit. Look for other causes. If you are not able to find any other cause and she has had 1, 2, or 3 abortions, then you should go ahead with septal resection. Incision or removal of the septum utilizing it can be done with cold scissors, unipolar or bipolar, cautery or laser. Insufficient evidence to say which method is superior during hysteroscopy removal. So these are some of the very big good studies, meta-analysis, and they show that hysteroscopic removal of septum seems to reduce probability of spontaneous abortions. Both the studies show the same. So coming to intrauterine adhesions, we come across these very frequently. These patients are presenting with oligomenorrhea. Sometimes they are not having periods at all. And many of them give history of tuberculosis or genital tract infections, PIDs, or they have been subjected to multiple DNEs and DNCs or MRPs, some intrauterine manipulation, previous hysteroscopic septal resection or polyp removal or fibroid removal. All these things are going to have a bearing. And because they are going to damage the basal layer, there may be formation of these adhesions. And they can be graded from 0 to 3, depending on whether they are flimsy or they are dense and whether the whole cavity is being obliterated. Why RPL occurs in these patients? Again, the endometrium, which is normally there, is replaced by fibrous connective tissue. And there is decrease in myometrium due to fibrosis, decreased in vascular supply. And the placenta is not able to form. If the placenta gets stuck there, then we are facing the placenta accreta syndrome every day nowadays because of these problems. Because if there is a scar, the placenta will not be able to migrate up like it does in other patients. So diagnosis can, as we have already discussed, it can be made on HSG or sonosalpingography or 3D ultrasound or MRI. Has in hysteroscopy, there we may find it difficult to negotiate the uterine cavity, and adhesionolysis can be done with Collins knife or scissors, and adhesion discovered during hysteroscopy in women with RPL are mostly flimsy, and there is no consensus whether you should give estrogen after that. Now we are not keeping any Lippes loop or any foreign body. Some people do put pediatric Foleys for some time and you can give them estrogen, but there is no consensus and there is no superiority of one method over the other. So now coming to the endocrine problem, the most important and problem which can be treated easily is the subclinical hypothyroidism. So we know that TSH level more than 10 milli-international units is overt hypothyroidism. All of them have to be treated. But subclinical hypothyroidism, which is between more than 4.5 to 5, should also be treated. And it has been seen that if the woman has got antithyroid antibodies positive and her levels of TSH is above 2.5, it is better to treat these women because for infertility patients and RPL patients, it is recommended that they should be treated. The APLA syndrome, antiphospholipid antibody syndrome, it is the only proven thrombophilia which is associated with poor pregnancy outcome. most treatable cause, and it affects up to 5 to 15% of RPL patients. What is the criteria? How can you diagnose Apla syndrome? So there's this Sydney division of SAPARO criteria, which was given in 2006. And if one clinical and one lab criteria out of these are the clinical criteria, the lab criteria, dono mein se one have to be positive, only then you can say that the woman has Apla. So in the clinical criteria, there could be arterial or venous thrombosis. During pregnancy, if she has had any of these problems, one or more death of normal fetus, more than 10 weeks, more than three recurrent consecutive abortions less than 10 weeks, and as we are seeing preterm delivery, severe preeclampsia, IUD, placental insufficiency, less than 34 weeks, then again, these are the clinical criteria. In the lab criteria, if you have anti-cardiolipin, antibody positive, IgG, IgM, or lupus anticoagulant if it is positive, or anti-beta-2 glycoprotein IgG, IgM if it is positive, then you can say if one of these two is positive, then we say it is APLA positive. And you have to repeat the titers again after 12 weeks because in number of viral infections and some other conditions, the false positive test may be there and the high titer needs to be there more than 440 GPL or MPL. So mechanism of action, we all know there is inhibition of cytotrophoblastic invasion and differentiation. Thrombosis is there, platelets, fibrinolysis and coagulation cascade is there, reduction in PGI2 and placental cell apoptosis. So what all problems can occur? Preterm labor, PROM, FGR, preeclampsia or eclampsia, placental abruption. So according to the green top guidelines number 37, the RCOG have given how to have recommended the how to treat these patients. So if you find that any woman is having APLA positive, but she has not had a previous history of thrombosis, then before pregnancy, you can start her on 150 milligram of low dose aspirin. Once she becomes pregnant and the cardiac activity is positive on ultrasound, you can start her on low weight heparin. The enoxaparin dose is generally 40 to 60. If it is a proven previous thrombosis case, then the dose will be more. Okay. So in the peripartum and at 36 weeks, you stop the aspirin dose and the enoxaparin can continue till one night before induction or till the time she goes into labor. After delivery, we know that it is a thrombogenic condition during pregnancy and after delivery. So you continue again for 6 weeks, both low molecular weight heparin and aspirin. Whereas in the APLA syndrome, where thrombosis is already there, previous history is there, then we are starting them on heparin or warfarin along with aspirin before pregnancy. And we need to start them on the therapeutic dose of 1 milligram per kg twice a day or 1.5 depending on the weight. If you are given unfractionated heparin, then APTT levels need to be monitored to 2 times above baseline. But with enoxaparin, such a stringent monitoring is not required. It is much simpler these days to use this. Genetic analysis, I'm not going to talk much about it because you have a whole session after this, my talk with the fetal medicine consultant. So what they say is that it provides benefit because it gives a reason. These couples are so worried. They are in so much of anguish. They want to know if they have committed some crime, what is happening, what is the reason for the pregnancy loss. So by doing this, at least you can give them a reason. And it also helps us to determine whether further investigations are required or not. You can do it after 2 abortions. You can send the POCs for the products of conception for karyotyping. And you can see that if it is an aneuploidy seen, then no further investigations. This is the cause. If it is a euploid karyotype, then the whole RPL workup that we are talking about will need to be done. If it is an unbalanced chromosome, then we have to send the patient for genetic counseling, and the parental karyotype is also recommended, and they have to go for either genetic counseling needs to be done, or they can go for adoption, donor oocyte, donor sperm, donor egg, and all the options need to be discussed with them thoroughly. Sometimes you don't give them any treatment, then also they can have a normal baby. So all these things have to be told to them. Genetic analysis of pregnancy tissue following pregnancy loss is not routinely recommended, and it is recommended because with karyotyping, the you are not able to capture, the culture will not grow in many cases, and there is also contamination with the maternal tissue. So the recommended investigation of choice is array-based comparative genomic hybridization. And parental karyotyping should be carried out after individual assessment for risk and for diagnostic explanation. So now we come to the biggest chunk, unexplained RPL. How to treat them? Should we give progestogen? Should we put a cervical surclage? Should we give enoxaparin? Should we give IgG to them? Lead therapy? What is to be done? There is so much of confusion. So the most important evidence is for progestogens. 2015 European Progestin Club says that if the woman has had 3 or more abortions, there is a reduction in the rate of miscarriage with the use of dydrogesterone. What does Foxy say? The good clinical practice says that oral dydrogesterone 10 milligram BD should be given till 20 weeks. And vaginal micronized progestogen, oral is not recommended. Vaginal micronized progestogen 200 milligram BD or 400 milligram per day should be continued till 20 weeks. What does the ESHRE guidelines say? ESHRE 2017 say that there is some evidence that oral dydrogesterone treatment, when fetal heart is there confirmed, then it should be given. And conditional recommendation that they had given earlier was that vaginal progestogen does not improve live birth, but we are getting good convincing landmark trials are there, and we are getting positive results in that. So how does progestogen act? It has this immunomodulatory action by reversing the Th1 Th2 balance, by modulating the chemokines, cytokines, interleukins, and also it has a uterine relaxant because it blocks the effect of oxytocin and PGF2 alpha and reduces contractions. So these are the various preparations which are available in the market. Oral synthetic progestogens, dydrogesterone is there, okay, 20 to 40 milligram. Natural micronized progestogen, we all know there are so many are there. 200 milligram BD or TDS can be given. In injectables, we have the choice in government hospital, my hospital. We are, when the patient cannot afford anything, we are even giving them this Proluton depot, that is the 17 alpha hydroxy progesterone caproate. Either you give 250 milligram twice a day, or you can give 500 milligram once a week. Micronized progestogen is there available in oil-based and water-based. And then we have the micronized progestogen in the vaginal form, capsules or gel is also available. So coming near to the end, you must know about the PROMISE trial and Dr. Ashok Kumar trial. So in PROMISE trial, they use micronized progestogen vaginally, 400 milligram BD after pregnancy test, 6 weeks, say 12 weeks. That. And they found no significant difference between those who were giving micronized vaginal progesterone and placebo. However, dydrogesterone, oral dydrogesterone showed a significant difference. If you gave dydrogesterone, the pregnancy continued live birth rate was much better and mean gestation age was much higher. Then there was this another landmark trial by Stevenson et al. And in this, they used the luteal start vaginal micronized progesterone. Instead of giving it in the previous trial, they gave it at started it at 6 weeks. But here they are giving in the luteal phase and continued. So this trial showed that there was improved pregnancy success. This was another important trial that you should know of. This is the Ismail trial. The periconceptional, again, they have given periconceptual progestogen and they have seen that the rate of preterm delivery was much lower. Then comes the PRISM trial. This was done for threatened miscarriages, and they found that in women who have had multiple miscarriages, they may benefit with vaginal micronized progestogen 400 milligram twice a day. So this is one of the, I think, last slides. The therapeutic interventions which are recommended for unexplained infertility. So they say lit therapy should not be used, IVIGG should not be used, glucocorticoid should not be used, heparin and even low dose aspirin should not be used. They give a strong recommendation of starting folic acid periconceptional period. Vaginal progestogen is a conventional okay for treating unexplained RPL. Insufficient data to treat intralipid therapy is not to be given. GCSF not to be given. Scratching, endometrial scratching is not recommended. So all these things are not recommended. And so at the end, just to summarize in a very short way, if the woman has had 2 or more abortions, the investigations which you must do are the APLA syndrome, because we can start them on aspirin or prophylactic enoxaparin as the condition may be. And you must do TSH testing T3, T4. And if the level is less than 2.5, levothyroxine can be started in these patients. Of course, overt hypothyroidism and subclinical hypothyroidism also needs to be treated. If there is uterine anomaly, 3D ultrasound is recommended, and or hysteroscopy can also be done. And if she is coming with recurrent abortions, you can think of doing a septal resection or removal of. I think this should be done. They have given a conditional recommendation, but I think in clinical practice, we remove the adhesions, because without that, the patient may not conceive only. She will have menstrual problems also. Submucous polyp, submucous fibroid, all these things need to be removed. And they say some are conditional investigations, which are the genetic tests, so that the patient can go for genetic counseling and patient knows what is the problem, why she's having these abortions. Immunological tests, not no specific treatment is available, so this should be done only on research basis. Sperm DNA fragmentation, if you get it done, the patient can be, husband can be told to go stop alcohol, tobacco, healthy lifestyle. You can give them some antioxidants. If it doesn't improve, you can go for donor sperm. To screen for hereditary thrombophilias is generally a conditional okay. But you should not screen the condition, the investigations which should not be done are other immunological tests and metabolic and hormonal tests. These are not recommended. And for all the patients presenting with RPL or infertility, lifestyle advice, which we just discussed, tender loving care, counseling, repeated counseling, and explain everything to them. These are the investigations which are available. This is what we are able to do. Half of them, we don't know what is the cause, and don't get disheartened. You can try again and again and start with some of the progestogens or enoxaparin. I have seen in our Lady Harding, when even when the apply is not positive, and many of the other clinicians I know, they are doing the same thing. You must have seen in your hospitals, if they are coming with 3 or more recurrent pregnancy loss, even if apply is negative, we are giving them enoxaparin and aspirin, and the pregnancy continues many times. IVIGG also, many people have said it is okay and it gives a good result. So depending on the patient's condition and clinical, how much she can afford and what is the available resource, you can monitor and tailor the treatment. So I thank you all for a very patient hearing. You are not audible, Dr. Manjusha. Please unmute Dr. Manjusha.
She is unmuted.
नहीं दे रहा है.
Hi, am I audible?
Yes.
Yes, ma'am. Manjushri, should I start?
I think if there is nothing else, then I will take your leave. I have another program at 8:15. So I'll take your leave. Thank you so much. And bye.
Thank you, ma'am. Should I start? Okay, ma'am. Good evening, everyone. Thanks for having me here. Today, we will discuss about some frequently asked questions regarding the prenatal aneuploidy screening, which we used to face in our day-to-day clinical practice. So, what is aneuploidy screening? If we will talk about the test, if one second. If we will talk about the screening tests are the tests which categorize the population into two categories, like high risk population and low risk population. So we used to run confirmatory test in the high risk population and we can confirm the diagnosis. In similar way, prenatal aneuploidy screening is a set of tests to assess the risk that the fetus has a chromosomal abnormality. Now, we used to face this question quite a lot, like whom to screen. To all we should screen, or we should screen only more than 35 years age group? Should it be a opt-in screening or opt-out screening? So we have to screen all, and it is an opt-out screening. Every female is having some background risk of having chromosomally abnormal baby. That risk is called as a priori risk. So uh, as the age increases, the risk for having chromosomally abnormal baby increases. But we have to remember that 70% of the trisomy 21 babies are born to mothers less than 35 years old. So that's why screening has to be offered universally. And yes, it is an opt-out screening, and we have to offer to everyone. But if patient doesn't want to accept the screening, then they can opt out. Now, all the dignitary bodies like ACOG recommends that all women who present for prenatal care before 20 weeks should be offered screening. RCOG antenatal care guideline also recommends the same. Screening test should be offered to all females in pregnancy so that they can choose to find out whether their baby is going to have a trisomy or not, and they can make informed choices whether to continue the pregnancy or not. WHO protocol also recommends the same. Now, when should aneuploidy screening to be offered? At the first visit, or at the time of anti-scan, at the time of TIFA, or after TIFA? So, the aneuploidy screening should be discussed and planned to all the antenatal patients, ideally at the first prenatal visit, whenever they are visiting us. But it should be offered at the time of 11 week to 13 week 6 days gestation, or earliest whenever patient is coming. It should be an informed choice. Now, which test is good? This is quite a dilemma, that whether double marker is good, or quadruple, or NIPT. So objective of screening test is to reduce the number of patients who are undergoing the invasive testing. At the same time, we have to increase the proportion of affected fetuses detected. So in short, we have to keep our detection rate maximum and false positive rate minimum. Now, if we will compare here, first trimester combined screening, that is anti-scan along with first trimester biochemistry, has detection rate 90%. Quadruple marker test is having detection rate 67 to 81%, while NIPT is having 99%. So all tests are good. All these three tests are good. But if we will see, triple test is having the lowest detection rate. That's why triple test is obsolete now. And we can discuss the screening test according to the gestational age patient is coming to us. Like if patient is coming before 13 weeks 6 days, we can offer them first trimester combined screening. If they are coming at the time of like after 15 weeks, we can recommend them quadruple marker test or NIPT. Now, which aneuploidy screening is good in case of twins? First trimester combined screening, quadruple marker test, and IPT, or all? All of these aneuploidy screening can be used in case of twins, but we have to counsel the patient that no form of screening is as accurate as in case of singleton. There is comparatively high false positive rate in case of twins when we are comparing to singleton pregnancy. In dichorionic pregnancies, risk is calculated for the each fetus, like individual fetus, fetus 1 and fetus 2. Whereas if we will see monochorionic pregnancy, risk is calculated for the pregnancy. So there will be a single risk. Now, if we will compare the detection rate of double marker and quadruple marker in comparison to singleton pregnancy, it is quite less. Double marker is having detection rate 70 to 80%, and quadruple is having 50 to 60%. So it is approximately 10% lesser than the singleton pregnancy. Now, in case of triplets, which screening test is better? No serum screening is validated for the higher order of multiple pregnancy, be it a triplet or quadruplet. NT-scan is the preferred method for the risk assessment for the chromosomal abnormality. So ultrasound screening is the good for triplet or higher order of pregnancy. Now a little bit about the NT-NB scan. So NT-NB scan is performed in between 11 week to 13 week 6 days gestation. Preferably CRL should be in between 45 to 84 because the FMF software or any other software, they don't calculate risk for chromosomal abnormality beyond DCRL, like less than 45 or more than 84 The software will not calculate the risk for having chromosomal abnormality. The NT-NB scan should be, image should be taken according to FMF protocol. In NT scan, we used to see sonographic markers like NT-nucleotranslucency, nasal bone present or absence, ductus venosus flow, tricuspid Doppler, and fetal heart rate. According to these markers, we used to calculate risk. We used to assign risk for the chromosomal abnormality in case of triplet or higher order of pregnancy. In besides these chromosomal abnormality risk assessment, in first that NTs can also it can detect 9 major abnormality like ecrania, encephalocele, alobar holoprosencephaly, exomphalos, gastrocchiasis, megacystis, limb reduction defect, body stalk anomaly, and anencephaly. So that's why NT scan is very important. Now, which serum screening to be offered in case of vanishing twin, and when to offer? Like it can be offered anytime or after 4 weeks of ultrasound diagnosis of the vanishing twin, or after 6 weeks, or after 8 weeks. So parents should be counseled regarding the potential limitation of the screening test. Anti-scan and anomaly scans are used for the screening and second trimester, and NIPT also can be offered, but it is important to wait at least 8 weeks after the demise of twin to ensure accuracy of the test. Now, first trimester biochemistry, we can do in between 11 week to 13 week 6 days. It can be done in case of singleton and viable twin pregnancy, but vanishing twin, it should not be done. And in more than twin pregnancy, like triplet or higher order of pregnancy, it should not be done. It should be done by the accredited labs only and on appropriate software only. Now, if first trimester combined risk is coming high, how to counsel the patient? This is the commonest thing we used to encounter in our clinical practice. Here is the report, sample of the report. We can see here, you can see highlighted parts. Beta HCG is showing 2.76 mom and PAPA is showing 0.26 mom. So it is very clear that beta HCG is high and PAPA is less. So the report shows final risk is 1 in 60, that is increased risk. We can see here clearly that this is showing high risk for the Down syndrome and preeclampsia. So the patient came to me for this high increased risk for the trisomy 21. Now, how to counsel this kind of patient? So practically informing points for the patient in case of screening positive. We have to tell the patient that yes, you are at the high risk, but your risk is 1 in 60. So there is possibility of one baby to be trisomy 21 positive in 60 babies. So yes, you have chance of carrying an affected fetus, but it is not a diagnostic test. It is still a screening test. So out of 60, there will 59 babies will be normal. Only one will have problem. So for that detection, we have to run additional diagnostic tests. And most common outcome is normal baby, like 59 babies will be normal. So we have to counsel the patient positively. In similar way, if it is coming as screen negative and patient wants guarantee from you, then we have to tell the patient that it doesn't guarantee a normal baby. It can detect only it can detect the chromosomal abnormality possibility only to some extent, not 100%. FMF protocol also says that we have to categorize the patient after first trimester combined screening in 3 categories like high risk, intermediate risk, and low risk. So more than 1 in 250 is considered at high risk, and they used to offer invasive testing directly. Less than 1 in 1000 will be low risk. In between 250 to 1000 will be considered as intermediate risk, and NIPT will be offered to the patient. If NIPT comes negative, patient will be considered as low risk. If it comes positive, then patient will be considered high risk, and invasive testing will be offered to the patient for the confirmation of chromosomal abnormality. So this patient I have counseled for amniocentesis, and the patient opted for the amniocentesis, and it unfortunately it came as trisomy 21. I will show report later on. Now next thing is soft markers. Quite often we used to get the patient who are coming with the TIFA report or anomaly scan report with some soft markers. So what are the soft markers? Soft markers are frequently seen in normal fetus. It increases the underlying risk, but it is not the diagnosis for the fetal aneuploidy. They are non-specific and they are insignificant by themselves. So, if we are getting soft marker in the anomaly scan report, then we have to recalculate the final risk for chromosomal abnormality. And how it is calculated? It is calculated by the likelihood ratio. And in case of particularly soft marker, counseling is paramount importance. Otherwise, patients are worried a lot, and sometimes patient will opt for termination directly without having any diagnostic testing. So these are some common soft markers for the trisomy 21, EIF, ventriculomegaly, increased nuchal fold thickness, echogenic bowel, renal pelvic dilatation, short humerus femur, aberrant right subclavian artery, and absent or hypoplastic nasal bone. So we can see here the likelihood ratio for individual markers are especially for URSA, absent nasal bone, and increased nuchal fold thickness and ventriculomegaly. Likelihood ratio is approximately 4 or 6, while others are having approximately 1. So these 4 are the major marker, while others are the minor marker. One more point, if there are two soft markers present, then we used to offer patient mostly directly the invasive testing. In case of isolated marker, we used to assign a new risk. A new risk is equal to priori risk, that is age-related risk, upon likelihood ratio of the soft marker. Now, another frequently encountered thing is if NIPT comes as no call or no result. So what to do? So NIPT, if we are sending, then it can come as low risk, high risk, or no call. So in 1 to 5% of singleton pregnancies, and in case of twin pregnancy, in higher proportion, NIPT can come as no call. So repeat testing can give a result in case of 60 to 70% of cases. The main reason for the failed NIPT is low fetal fraction, low proportion of fetus to total self-free fetal DNA in maternal blood. So in trisomy 18 and 30, the fetal fraction is much lower. That's why if patient is coming with no call report, the first option should be given of invasive testing, as it is considered as increased risk for the trisomy 18 and 30. This is a normal NIPT report. We can see here fetal fraction. We have to, if we are checking the NIPT report, we have to check this fetal fraction. If fetal fraction is less than 4%, then it is considered as low fetal fraction, and we have to be careful. And ideally, it should be more than 8%, 8% good fetal fraction, but labs claim 4 to 8% is also normal for them. Now, another question is, if couple is having previous affected child with the trisomy 21, what to do next? So if affected child is available, then we have to run karyotype in index child. If it is not alive or not available for the evaluation, then parental karyotyping should be done. So there are three types of Down syndrome. 95% are the trisomy 21, rest are balanced translocation and mosaic type Down syndrome. So it depends upon the previous child's karyotype what to do in next pregnancy. So if it is trisomy 21, that is pre-trisomy, the recurrence risk is 1%, and fetal karyotype should be offered only if routine screening is abnormal. So in these cases, we have to offer routine serum screening. If there are translocation involving chromosome 21, then parental karyotyping is to be done. If parents are not carrier, then routine screening. If parents are carrier, then we have to offer invasive testing. Similarly, in case of mosaic trisomy 21, fetal karyotyping is done only when routine screening comes abnormal or high risk. But what happens if patient is having previous Down syndrome baby, then they will be very anxious. So if patient wishes, then we can go ahead directly with the invasive testing. Now, which invasive testing is good, whether CVS or amniocentesis? So it totally depends upon the patient presentation, gestational age, which test to be offered. If patient is coming in between 11 week to 13 week 16, then chorionic villus sampling. After 15 weeks, amniocentesis. So both tests are good and equally effective, but risk of miscarriage is slightly higher in case of CVS. That is 0.2 to 0.5%. And one more additional thing is there in case of CVS. It can sometimes mosaicism can affect the result in case of CVS because we are drawing the placental tissue. Sometimes what happens, placental karyotype and fetal karyotype can be different. So that's the time when we have to offer again amniocentesis after CVS. So these are the procedures. This first one is showing amniocentesis. Ultrasound guided needle is put in the amniotic cavity, and we used to withdraw 20 to 22 ml amniotic fluid, and we used to run chromosomal microarray or karyotype or the recommended testing in amniotic fluid. In similar way, the chorionic villus sampling is to be done. The trophoblastic tissue is withdrawn and the test is run in this tissue. So this is the report of a karyotype. Here we can see the 21 chromosome are like there is one extra chromosome along with the 21st pair of chromosomes. So this is the pre-trisomy 21 or trisomy 21. In this kind of patient, we need not to do invasive testing directly in next pregnancy. We can offer screening test also. Now at the end, regarding the screening test, choose the right test at the right time. Counseling is must. Both pre-test and post-test counselings are must. In pre-test counseling, we have to tell the patient what to expect in result and how we will proceed further. In post-test counseling also, we have to assure the patient and we have to document whatever we are offering. Also keep the option of no screening open if patient wishes. Like in some cultures, patient wishes that they don't want to terminate the baby, then there is no point of a screening test. So we have to tell the patient that after a screening test, if it is coming as high risk, then we will offer you a definitive diagnosis test. And if it shows a chromosomally abnormal baby, then we will offer you termination. So if patient doesn't want to opt for abortion or termination, then there is no point of doing a screening test. And in case of high risk results, we have to do further counseling and additional tests should be done and follow-up should be taken. Confirmation by the invasive testing is must before opting for the termination, because a lot of patients used to come in OPD with the previous baby was terminated with the high NIPT reports. So it should not be done because we will not have any idea what the chromosomal structure was there in previous pregnancy, and we cannot counsel in next pregnancy. So it becomes difficult if we are not having previous pregnancy data. Thank you. Thank you so much.
Big thank you to both the speakers, and thank you, Shipra. You have really told us in very crisp and clear words what we should do, what test to do, what not to do. And especially, I'm really grateful that you put up the points like NIPT showing less than 4% fetal fraction being not so good to evaluate results. I mean, a big thank you to you for putting such clear-cut messages across. And even though I understand that Dr. Piki is not on board with us now because she had to leave for another talk, but she has given us some very, very important points, like abused treatments, things like IGT and progesterone overloading and cavity corrections and septal dissections. So the point which I want to emphasize upon to all of us here is that these things are not evidence-based, and we must practice evidence-based medicine, especially in scenarios like this. Now we are going over to the next very important session, and Dr. Shikha is with us, and we shall be now doing the quiz. Shikha, I think most of what you have asked has been covered in the lectures. So somebody who has been listening to the lectures carefully would really get 100 on 100, right? Over to you,
Definitely, ma'am. Yes, ma'am. So am I audible, ma'am?
Yes, perfectly.
So we'll be now going to the quiz. So I hope all of you, all the participants have downloaded the Kahoot app.
For those of you who might be new to Kahoot, there's a pin flashing on the screen. You need to open up the app and put this pin on the screen so that you are on the Kahoot link. Some of the names I see here are repeat participants. So I think you all know that you have to join it with mobile numbers and not names. It makes it easier for us to communicate with you later. Shivangi, please join with your mobile number.
Dr. Neha,
please join with your mobile number. Neha and Shivangi. You go to the Kahoot and then you change the number, change the username. It shows as nickname. So the nickname should be your mobile number, not the good name. Shivangi, please change. Would you like to brief them about the rules?
Yes, ma'am. So we have a total of 20 questions. All are multiple choice questions with 4 options each, with a single correct answer. So we'll get a total of 20 seconds. That includes me telling the question as well as answering. And there is only a single correct answer, and the scoring will be based on the accuracy of the answer as well as the speed. So the fastest finger gets the maximum marks.
And we have been giving certificates to the top 3 scorers, and we'll be having one grand quiz at the end of the series, which will be in November. And all the toppers of all the quizzes we have held since January, they would be contesting the grand finale, and the winner of the finale moves on to the competition quiz. I see a lot of repeat names here, and I'm so happy to have you girls and boys back with us month after month. Shika, the topic we have on early pregnancy and applied genetics, am I right?
Applied genetics, yes, ma'am. Yes, ma'am.
So we have 13 people. Anybody else joining in? We have 23 participants showing in the Zoom and 13 in the Kahoot. So if anybody is having any concerns joining, you may please put in the chat box. Shikha, if there are no more additions, shall we lock the Kahoot room and get going?
Yes, ma'am.
Himanshu, are you ready? Okay, there we go.
So the first question, ultrasonographic findings, diagnostic of pregnancy failure according to ACOGR. No cardiac activity with CRL 7 mm or more. No cardiac activity 2 weeks or more after ultrasound detected GSAC without a yolk sac. No cardiac activity more than or equal to 11 days after ultrasound detected GSAC with yolk sac, or all of the above. Yes, so most of you have got it right, 9 participants, all of the above, all are criteria. So coming to the scoreboard, okay, the fastest finger has got the highest score. Next question. Which of these is not true about Robertsonian translocation? Carriers may produce normal offspring. Rarely, this translocation leads to Down syndrome. Mostly affects telocentric chromosomes, and carriers are usually phenotypically normal. Okay, so only 2 people have got it correct. It affects the acrocentric chromosomes. Shivam, can you just pause for a minute? Yeah, so this affects the acrocentric chromosomes. Here, the long arms of the acrocentric chromosomes like 13, 14, 15, 21, and 22, they may fuse. One of them, 2 of them may fuse together. And hence, in the carrier itself, it will be, because the chromosome, this thing will be same, but the short segments will be lost, which don't have important genes, so it will be normal. However, they may have some unbalanced uh, gamete, and those unbalanced gamete, and it can lead to a problem in the offspring in around 25%. Next question. Okay. So this is a scoreboard. Next question. Which is the commonest genetic anomaly associated with sporadic early miscarriage? Microdeletion, monosomy, trisomy, or SNPs? So trisomy is the answer. Only 3 have got it correct. So monosomy is quite rare. So trisomy is the commonest, followed by polyploidy. So let's have a look at the scoreboard now. Okay. So one each answer. Okay. Which congenital uterine anomaly is most likely to be associated with sporadic first trimester miscarriage? Didelphus, bicornuate, septate, or unicornuate? So 10 people have got the correct answer. Septate uterus is the anomaly which is most commonly associated with first trimester miscarriage. And if metroplasty is needed at all, it has to be done for septate uterus. Scoreboard, please. Next question. Which is the recommended test for genetic analysis of products of conception? Conventional karyotyping via tissue culture, fluorescence in situ hybridization, chromosomal microarray, or next generation sequencing. So 9 people, most of you have got it correct. This was already discussed by Dr. Picky ma'am in her talk. So this chromosomal microarray, also called as array CGH, is the recommended test to look at this. Okay, scoreboard. So 98889784146 leading with highest score. Others are slightly behind. Next question, please. Which of the following is the more specific and sensitive test for detection of lupus anticoagulant? DRVTT with platelet neutralization, APTT, Cowlin clotting time, or none of the above. Okay. So yes, dilute Russell-Winome Viper test is the more specific one, and 7 people have got the correct answer. So this has been mentioned by Green Top guidelines also that this is the more specific and sensitive test. Scoreboard, please. Okay. So 4 participants have reached the answer streak of 3. So everybody, well done. Let's continue. Next question. If the husband of a thalassemia minor woman is a carrier of dash, offspring is unlikely to have thalassemia major. HBC, HBO Arab, HBE, HB Lepore. So we have got only 4 correct answers. So basically HBC does not cause thalassemia major-like disease. Even in 25%, it may cause thalassemia intermedia-like disease maximum. All the other 3 in 25%, it will cause major thalassemia major-like disease in combination with thal minor. Next question. Okay, so 8606096611 is leading. Next question, please. Which of the following is not a feature of cervical pregnancy on ultrasound? Empty uterus with barrel-shaped cervix, presence of gestational sac below the level of internal os, presence of sliding sign, hypervascular trophoblastic ring in cervical canal. Yes. So everyone has got it correct. So there is absence of sliding sign and not presence in cervical pregnancy. All other 3 are the diagnostic criteria. Well done. Scoreboard, please. Great. So the same person is leading, and the second person is quite close with an answer streak of 5. Well done. Next question. When is levothyroxine not needed in the treatment of RPS? So presence of anti-TPO antibodies with normal TSH, subclinical hypothyroidism, overt hypothyroidism, none of the above. Not needed. Correct. Surprisingly, only one has answered correctly. So this is the updated guidelines by ASHRAE 2022. So they have mentioned even if the patient has antibodies, but if the TSH is normal, you need not treat them, should not be treated with a strong level of evidence. So, okay, coming to the next question and scoreboard. So only one person has got it correct. Okay. So this is the take-home message. We should not treat the women with a normal TSH even if they have the antibodies. Next question. Which of the following is not a feature of Fragile X syndrome? CGD triplet repeat 5 to 40 times, X-linked dominant condition, autism spectrum disorder occurs more frequently in these people, women with FMR3 mutation at increased risk of having child with Fragile X syndrome. Okay, so 3 people have got it correct. The CGG triplet repeat 5 to 40 is normal. So in these patients, they have it more than 200 times. And in the pre-mutation, it is 40 to 200. So 5 to 40 is the normal. So this is the correct answer. It's not a feature. And autism and attention deficit disorder is quite common in Fragile X syndrome. So this is A is the correct answer. Scoreboard. Okay, so 8439352 is leading, and the second person is close. Second and third are quite close. So next question, please. Which technique is used to sequence short cell-free fetal DNA fragments? PCR, gel electrophoresis, next generation sequencing, or FISH? Good. So 7 have answered it correctly. It is the next generation sequencing for NIPT. So let's look at the scoreboard now. Okay, so we have very close first, second, and third going on. It's just the 11th question which has gone. So everybody need to pull up your socks and all the best. Next question. All of the following could be a reason for high false positive rate with NIPT, except vanishing twins, maternal malignancies, confined placental mosaicism, or DCDA twins. Okay, so only 4 people have answered it correctly, DCDA twins. As Dr. Shipra has already mentioned, vanishing twins, if we do closely to the vanishing, when it has just vanished, it will be releasing a lot of cell-free DNA in the maternal plasma. So the value will be falsely positive. Similarly, maternal malignancy will cause a false positive, and even placental mosaicism. Twins, routine dichorionic diamniotic twins will not lead to a false result. Next question. Scoreboard first, yes. Okay, so we have got a new leader. So well done. Next question. Pentamarker screen involves testing of all of the following maternal serum markers except HCG plus AFP, inhibin B, PAC-A, and placental growth factor, PLGF. Okay, so only 3 people have got it correct. It is inhibin A and not inhibin B which is tested. Both for quadruple marker and pentamarker, it is inhibin A to be tested. So this was a trick question. Okay, let's have a look at the scoreboard. Okay. So 8439352 is leading. We still have around 7 questions to go. So, okay. Next question, please. Which of the following is not true about contingent screening? Result is obtained only at the end of second trimester screening in all cases. Low-risk patients after first trimester screening need no further testing. Patients at high risk are offered diagnostic testing, and NIPT is offered in intermediate risk patients. Correct. So it is of the result is at the end of first trimester screening itself. We'll get to know if it is low risk, they will not be undergoing any further testing, and high risk will undergo invasive testing directly. Intermediate will be offered cell-free DNA or NIPT. So the first option is wrong because we don't wait till the end of second trimester screening in all cases. So only 3 people have got it correct. Scoreboard, please. So we have the same person leading, and there's everybody else is nearby only. Okay, let's go to the next question. An increased NT measurement increases the risk of all of the following except heart defect, diaphragmatic hernia, abdominal wall defects, or cranial anomalies. So cranial anomalies is the right answer. So 2 people have got it correct. So increased NT in addition to the increased risk of chromosomal abnormality also tells us about other defects risk of. So including heart defect, diaphragmatic hernia, and abdominal wall defects, but not neural or cranial defects. Scoreboard, please. So we have got a new leader now. 86060966611. Well done. Next question, please. All of the following is true about osteogenesis imperfecta except type 4 is lethal in the perinatal period. It occurs due to mutation in COL1A1 or COL1A2 genes. It may be hereditary or occur de novo. Blue sclera are a classic sign in many cases. So yes, option A is correct because this is not true. Type 2 is the lethal one and other options are all correct. It is due to suboptimal collagen, type 1 collagen production because of these mutation in these genes called A1 and A2. It may be hereditary or de novo, and blue sclera is a classic sign. It is seen in many of the cases, most of the cases. So only 3 have got it correct. Let's see the scoreboard. The same person is leading. Well done. And others are close by. Which of the following statements is true about von Willebrand disease? What is true? So von Willebrand factor gene is located on chromosome 14. This disease may remain asymptomatic due to incomplete gene penetration. Type 1 and type 2 are inherited in autosomal recessive pattern mostly. Type 3 can be inherited in autosomal dominant pattern. Yes, so option 2 is correct. And 3 people have got it right. So this disease may vary. The symptoms may vary. It may be very mild to very severe. Generally, type 1 and type 2 are autosomal dominant and they are the milder forms. And type 3 is the autosomal recessive type and it is the more severe form and generally leads to bleeding in joints, etc. and spontaneous internal bleeding. And the gene is located on chromosome 12 and not on 14. So yes, coming to the next question and scoreboard. The same person is leading. Well done. Others are also quite close by. So everybody, yeah, we still have 2 more questions to go. 3 more questions to go. Which of the following statements is not true regarding congenital polycystic kidney disease? Autosomal recessive PKD is often diagnosed in utero or shortly after birth. Liver involvement is more severe with autosomal dominant variant. Autosomal dominant PKD is usually diagnosed in adulthood, and both types can lead to kidney failure and require dialysis or transplantation. So B is the correct answer. 2 have got it correct. Liver involvement is more severe with autosomal recessive type. So generally, what pattern I've seen in autosomal recessive type of diseases generally have more severe and earlier involvement, be it von Willebrand or PKD. So in most of the diseases, autosomal recessive have more severe presentation. Okay, coming to the scoreboard. The same person is leading and very close second and third. Next question, please. Which of these is true about anencephaly? Affects 1 in 10,000 pregnancies. Family history of neural tube defects does not increase the risk of anencephaly. It generally follows a multifactorial pattern of transmission, and oligohydramnios may be seen on ultrasound. So two people have got it correct. It generally it follows a multifactorial pattern of transmission, and it affects only one in thousand pregnancies and 1 in 10,000 newborns. So option A is not right. And B, option B, because neural tube defects family history does increase to a certain extent the risk of anencephaly, and polyhydramnios is seen on ultrasound. However, the transmission is affected by a lot of factors, including folic acid deficiency, hereditary, and other factors. So this is the right answer, multifactorial pattern of transmission. Scoreboard, please. So yes, we have got a new leader. So 80098272288 is back with an answer streak of 3. New leader, yes. Well done. So others are also close by. We have one more question to go. Last question. Which chromosomal abnormality does not have a higher no-call rate in NIPT? Trisomy 13, trisomy 18, trisomy 21, and sex chromosome aneuploidies. This was already discussed by our previous speaker, Dr. Shipra, very clearly mentioned. Okay, so yes, trisomy 21 is the answer. So whenever the patient, the report comes as no call, we have to advise them for an invasive test because they are at high risk of having either Edward or Patau syndrome 13 and 18, but not 21. And also in some cases, sex chromosome aneuploidies. So C is the correct answer, trisomy 21. So 4 people have got it right. Let's have a look at the final scoreboard. Okay, great. Congratulations. Wonderful.
I would request all the winners to please put in their names and email addresses in the chat box so that we can be sending across your certificates.
So
All the winners,
congratulations
please
to
put
all
your
the
names in the
winners.
chat box.
I would like to thank Dr. Manjusha ma'am.
Shikha, I want to thank you for coming up with such wonderful questions, very interesting and very practical. But then, yes, I also want to tell the children, the youngsters with us right now. It seems that you guys are missing out a lot on medical genetics, the applied genetics. But now is the era that we are looking for genetic basis of diseases in anything and everything, and more so in prenatal abnormalities and congenital diseases. So, Dr. Shikha has touched upon so many different conditions which are important, which are more common, and somehow you guys have not been really reading about that. So, that's why we got so many wrong answers. But then I think we are all in learning stages, and it'd be nice if we could go back and read up on these issues, like things like which Shikha mentioned about, let us say, anencephaly. We all know that it is multifactorial. It happens 1,000 live births. She was talking about von Willebrand disease. Von Willebrand disease is one of the more common causes of polymenorrhea. So, and it has incomplete penetrance. So we got to be knowing a little about these things. So thank you, Shikha. You brought up important things which we as learners should be knowing. And
Thank you so much, ma'am, for guiding me throughout. Na? So this is my first time as the quiz master, and you have like helped me throughout from the first day itself with the quiz. So thank you so much.
And I think the candidates did wonderfully well. Sukriti happens to be our repeated winner. So again, she's at the first track. Shivangi from Manipal, third place. Can I have the second place person also so that we can be sending across your certificates? And I must thank Shipro also for putting such an important thing in an FAQ format. It's so easy for us to comprehend. and so easy for learners to have a take-home message.
Thank you, ma'am, for guiding me.
It's all a pleasure and it's all mine. I want the second Nihalika Gupta. Please put in your name and email address at one place so that I can take a picture and we can send across your certificates. Another thing is that the next session would be on the third Thursday of next month, which I guess falls on May 17th, if I'm not mistaken.
June
Sorry,
17th.
June 19th it would be. June 19th, yes. And the topic this time would be on fertility preservation. And let me try and find out what lectures can I arrange for you guys. And quiz also would be on fertility preservation. And I would like to cover both the surgical aspects, the fertility preserving surgeries, as well as the fertility preservation by means of things like oocyte preservation and things. So I would like to see many more of you in the next quiz, and I would request all the youngsters who are with us on the quiz to please spread the word around to their colleagues and seniors and juniors to be a part of this quiz. I really hope that you all learn as much as we enjoy making it and learning it. I hope that you also learn with this quiz. And if there's any specific feedback which any of you want to give it, I'll put in my phone number in the chat box and you may give me your feedback so that we guys can devise quizzes appropriately for all of us to learn better. Yeah. So should we call it a day?
Ma'am, I had a small question for Dr. Shipra, if she's still there.
Yeah, she's present. She'll be very happy
Yeah.
to answer.
Dr. Shipra, so like I have a patient who's a combined screening report, na? So it has come as 1 in 2,100 something. However, the double marker shows a MOM for beta HCG of 5, MOM of 5. And PAPE is around 0.88 MOM, so that is normal. So I'm wondering whether a single marker, if it is very high, is it a this thing for NIPT? Should I advise for NIPT or it's okay?
If overall risk is not high, then NIPT is not required. But yes, if beta ECG is very high, like more than 2.5 mom, then we can advise serial growth scan for the patient for growth monitoring, because this high beta ECG and low PAPA, it is also associated with the fetal growth restriction.
Okay.
So
Okay.
patient will require 4 weekly monitoring for the growth. And what
Growth.
happens sometimes, if there is problem issues in transportation or especially in
Hmm.
summer, beta HCG can be high. Like this, we have seen a lot that beta false high of beta HCG.
Beta HCG, but ours is a very standardized this thing. Na? We are like doing lots of cases, big hospitals. So this has never happened because beta HCG MOM is 5, more than 5. So
But
that's okay
NIPT is
because
not recommended in these cases. Overall,
not
risk
different.
is not high. It
No
is
problem. Okay.
no problem.
Okay. Thank you so much.
Okay.
And thank you for that question and that wonderful answer. And before I end, I must thank all the audience for being with us and being patient with us, and not to forget Mr. Himanshu, the backend team, without whose endless support this program would never be possible. And thank you, Geeta ma'am, for being with us and encouraging us always. Thank you all, and I hope to see you all again on the 17th of June with a newer topic. Thank you. Bye bye. Have a great day.
Thank you, ma'am. Thank you, everyone.
Thank you. Bye.